So if you had a child who's got LCH, or even without, who's drinking a lot and peeing a lot, if you checked in early morning, first thing in the morning, if they've managed to go through the night without too much to drink, check a morning blood and a urine and pair them together at the same time and match them. And if the blood's very concentrated and the urine's very dilute, then the body's obviously not doing its thing. Basically, if you've had enough fluid, then you pee enough. If you haven't had enough fluid, you don't pee. And if the body hasn't got that right, then you need to go further to the next test. And that's the water deprivation test. So we admit them overnight. It's very, very stressful, especially with a toddler. You have them screaming for hours because they're desperate for a drink, and you have moms in pushchairs or driving around town, hysterical, because they don't know what to do with them. Test them from 8 a.m., no fluids. They can have little bits of something to nibble on, but no fluids. And if you can imagine, if they're peeing a litre every hour, and you're not giving them anything to drink, they're going to get very, very upset. The important thing is to weigh them at the beginning. If they lose more than 5% of their weight, you've pushed them too far, and you're going to get them dehydrated. Check how much urine they're producing, and check their blood tests. So if no fluids going in and lots of fluids coming out, then that's likely to be diabetes insipidus. It's very simple. And if it doesn't concentrate and the urine stays very dilute, we give some of the medicine, measure it again, and see what happens. And if it is diabetes insipidus, then the next urine will concentrate. In fact, they might not pee again for hours. The treatment is desmopressin, and as Dr. Whitlock mentioned, there are tablets now, but the tablets are quite a large strength. So for the babies, you might have to use the liquid. And the liquid's really fiddly because it's got a long glass tube with a little bulb at the end. And you use sort of 0.01 of a mil, which is absolutely tiny. And anywhere from that upwards for a baby. There's a spray, which is quite convenient, and the teenagers quite like that. And then there's the tablets. It's given 2 or 3 times a day, and some of the teenagers get very good at handling it. And if they find that they're beginning to wee a lot, then they'll take a puff of the spray or half a tablet and then carry on. So they'll titrate their dose depending on how they feel. That's a problem with teenagers and adults. Alcohol has the same effect as diabetes insipidus. It stops ADH production by the brain. So if you drink too much, you end up weeing a lot. And that's one of the things. If you don't take your medicine and you drink, you're in trouble. So they need to remember to always take the medicines before they go out. The growth hormone deficiency, 10-15% of the multi-system LCH. We don't tend to see it in the single-system LCH patients. Radiotherapy is a cause. Much less now, but in the past it used to be because radiotherapy was used quite liberally. In children, the simplest way to find out is looking at their growth. All children should be measured at each clinic visit and the growth plotted on a chart. The normal growth is about 2 to 3 inches a year. And if they're not growing that during the ages of, say, 3 and 10, then they're dropping off their lines. And if we plotted them on a line, they start dropping off further and further. You know they're not growing properly, and they need to be investigated. So anyone with slow growth, and if they go into puberty and don't have a spurt, then that's the other time to think about it. They tend to be relatively overweight, so just that little bit fatter than they should be. And some of them will complain of tiredness, poor muscle strength, don't like going and doing sport, and would rather sit around. So the growth hormone stimulation tests are slightly more complicated. They involve being starved overnight, staying in for between 4 and 6 hours, depending on which test you use. And they're chemical tests, so you inject a hormone and you measure growth hormone levels over time. But it's quite a good way of deciding whether someone has growth hormone deficiency. Because one of the problems with growth hormone, if you did a single blood test at any time, you can never be too sure. If it's in the normal or high level, then it's okay. But if it's low, you don't know whether they're growth hormone deficient or not till you stimulate it. We do an MRI of the brain and pituitary. We do a bone age, and a bone age is an X-ray of the left hand and wrist. And it gives you some idea of how young the body thinks it is, what age it thinks it is, and you find that the bone age will go along with the height and with the puberty, but not necessarily with their actual age. And it gives you an idea of how much catch-up growth they've got once you start a treatment. The other thing in older children is to look at a bone mineral density, and that looks at how strong bones are. I've heard about osteoporosis in older people. Well, children who are growth hormone deficient can get osteoporosis. Treatment is growth hormone replacement, daily injections. We haven't yet got an oral preparation, but it's a pen device, so press a button. It's as simple as that. You don't have to drop and stick a needle in your child. It's every day till they finish growing. They're fine till they're 14 or 15, then they decide they don't want it anymore. And then they come back when they're 20 and want to be taller, and there's nothing you can do about it. They have to have it during the time they're growing. The dose is adjusted according to their size, and I always tell them, if you've decided that's how tall you want to be, and you want to stop it, that's fine, but don't expect me to do anything later. There are no major side effects. Sometimes some of them get headaches. Stop it for a while. You can restart at a lower dose and build up again. There's no evidence that it causes either recurrence or worsening of LCH. The one thing I tend to say is if you've got active LCH, then there's not much point using growth hormone at the time because the body just doesn't grow and doesn't respond as well. The other thing is if you're on treatment for LCH, the prednisolone stops you growing anyway. And it's a bit of a waste having one medicine that's trying to cure your LCH and stops you growing, and then trying to make them grow with growth hormone. So just wait for 6 months or a year. Once they come off the treatment, start the growth hormone. Some adults might need growth hormone long term, and that's because we all make it, and it keeps us strong and keeps us well. And if your growth hormone levels are very, very low, then you might need it as an adult. But it tends to be 2 or 3 times a week, not every day. You asked about the sex hormones. They tend to be the next hormone that gets knocked off, but quite often they're part of what we call panhypopituitarism. Pan meaning everything, or all. And rarely all the hormones can be knocked off. So they tend to have poor growth. The delayed or arrested puberty is a classical sign of sex hormone deficiency. But what you need to remember here is it's not a primary problem with either the ovary or the testes. It's not the estrogen that's low primarily. The problem is the hormone that's coming from the pituitary gland, the LH and the FSH. And what they can do is in a younger child, they'll cause a delay in puberty. And sometimes if the first diagnosis is in a teenager, they might start their puberty and stop halfway through and then not progress. And that's something that needs to be diagnosed as well. They put on weight, they could have an underactive thyroid, and the most dangerous bit is the poor stress response. When you and I are stressed, our blood sugar levels go up, our cortisol levels go up, and that protects us. If your pituitary doesn't work, your cortisol levels don't go up. These children can get very, very low blood sugar levels. They just don't respond to stress. So they need to be on cortisol replacement for life, and also have emergency supplies for if anytime they become very unwell. It needs a combined test. So it's something like the other test for growth hormone, except you measure all the other hormones as well and give them further medication. And the treatment is basically replace all hormones. Now this is something that we've been fascinated by for quite a while. We don't understand why it happens. There's 3 different bits to it. There's the eating disorder, which leads to obesity. There's a temperature instability and behavioral changes. They can binge eat, so they'll eat for England for about a few weeks, stop eating, or even a day. They'll eat 6 meals one day and nothing for the next couple of days. And we don't know whether it's because they've lost the ability to know when they're full. Obesity I'll talk about in a second. And this is classical, unfortunately rare.